Okay, hello dear students. So today our practical classes topic is the hemocirculatory disorders. Not only the hemocirculatory and also the lymph circulatory disturbances. And we have some topics to discuss with you. First, the hyperemia, then thrombosis, the embolism, ischemia, infection we discussed with you during the necrosis, hemorrhage, and edema. Hyperemia. What means hyperemia? Hyper, more. Emia is blood. Is the local increase in volume of blood in a particular tissue. There are two types of the hyperemia, the active hyperemia and passive hyperemia. Active hyperemia, this is the active process that results from the increasing the arterial blood inflow for the arteriolar dilatation. So because here the increasing number of the arterial blood, the tissues became the red color with the oxygenated blood. The passive hyperemia, this is the passive process that resulting from the impaired venous outflow from a tissue. So the affected tissue has a red-blue color due to the accumulation of the deoxygenated blood. There is the ischemic illustration of the normal arterial microcirculatory network. Here you see the arteriole that belongs to the capillary network and the formation of the venule, and the comparison of the hyperemia, or another term we call the erythema. And the erythema, this is the clinical signs, like the rash in the skin and the congestions. You see here mainly the dilatation of the arterioles, and here the capillaries and venules. So there are two types of the arterial hyperemia, the physiological and pathological. For the distribution, it can be general and local. What the symptoms of the arterial hyperemia? As we said, the redness of the skin and the mucous membrane, the dilatation of the small arteries, arterioles, veins, and capillaries, the increased number of the visible vessels and their pulsation in the affected area, increasing the local body temperature, increasing the pressure in arterioles, increasing metabolism, and etc. Etiology of the arterial hyperemia. First, the mental factors, the biological factors, chemical, mechanical factors, and increasing function of organ. The causes of general pathological arterial hyperemia, this increase of plasma volume and erythrocytosis, increasing the number of the erythrocytes, such as the primary and the secondary. As we said that there are two types of the arterial hyperemia, the physiological and the pathological. The physiological hyperemia may be found in the normal life conditions. For example, in the skeletal muscles during the exercises, in the intestines after the eating, or the blushing or the flushing of the skin of face in response to the emotions, in the menopausal flush. But pathological arterial hyperemia we'll discuss with you in our next classes during the discussion of the inflammation, acute inflammation. So there are some types of the local pathological arterial hyperemia. Angioneurotic, or another term we call the neuroparalytic, due to the innervation lesion. Collateral, you know that in some organs have the collateral blood supply during the obstruction of the main source, main artery. The collaterals stay open, Then hyperemia after ischemia. For example, after elimination of the ischemia factor, after the removing of the tumor, ligature, and the organs, they receive the more blood. The vacatose hyperemia due to the decrease in barometric pressure, and inflammatory hyperemia that we will discuss in next classes. It was the active hyperemia, the increasing the blood flow of the arterial blood. Now let me discuss about the passive hyperemia. It is the increasing of the venous blood in the organ as a result of obstruction of the venous outflow, venous drainage. So the veins, venous, and the capillaries in the organ become passively dilated. We call it the passive hyperemia. Also, there are the acute and chronic types that localized and generalized, acute and chronic. The symptoms is in contrast to the active hyperemia. Here is the dark red color of skin and mucous membranes. We call it the cyanosis. Increased tissue of organ volume, the low body temperature, increasing or the local temperature, increasing pressure in the veins and capillaries, slowing of the blood flow, the stasis, edema, diapedesic hemorrhage. You pay attention, and you have to remember that in the organs, if there is the hypoxia, it will result to the dystrophy or the degeneration and the necrosis, and finally the sclerosis and atrophy. This is the general rules of the pathology. So, acute localized venous congestions. It may be due to the sudden complete venous obstruction by thrombosis or the ligature that will result with the edema and the hemorrhage due to the rupture of the veins and capillaries. So, etiology of the venous hyperemia, the general venous hyperemia and the local venous hyperemia. General venous hyperemia, they resulted by the heart failure, because we'll discuss the cardiovascular pathology in the next term. There are some functions of the heart. One of them, the pump of the blood, and another one, the drainage of the venous blood. In the heart failure, the drainage function of the heart is false, and the organs became to the hyperemic, the venous hyperemic. So there are two types of the general venous hyperemia, acute and chronic. In the acute heart failure, they result with the acute general venous hyperemia. In the chronic heart failure, or the chronic general venous hyperemia. But the local venous hyperemia, it results by the local features. For example, thrombosis of the veins, or the external pressing of the veins by tumor. As we said, that they affect the formation of the edema in the organs, the stasis of the blood, the stopping flow of the blood, and development of the varicoses. And here you see the development of varices in the low extremities veins. But the acute, as we said, the generalized venous congestions, they result by the acute heart failure that affects the rapid generalized congestions in the all of the viscera, that internal organs. And chronic, we said that is related with the chronic heart failure, chronic right-sided heart failure. During the chronic passive congestions, the internal organ became to the congestions with the venous blood, For example, the liver. You know that the liver receives the blood from the two sources, from the hepatic artery and the portal vein, and when the blood flow, they blockade. The venous blood remains inside of the liver, and you know that here this is the histologic pictures of the liver. From the histology, we know that there are two zones in the hepatic classic lobules. Zone 1 in the portal tract area in the periphery, zone 2 and zone 3 around the central vein. As you know, that the zone 1, they receive the so highly oxygenated blood than the zone 3. So the zone 3 is so very sensitive area for the starting of the necrosis. And here you see the sinusoid, the dilatation of the sinusoids and the bleeding of the erythrocytes to the stroma of the liver. So here, this size, we see with you the red color. In the periphery, due to the hypoxia, here develops the fatty degenerations of the hepatocytes. In the gross view, this is the gross view of the congested liver. It resembles the nutmeg. So we call this is the kinds of the nuts. Probably you know this fruit. We call it the nutmeg. And the section of the liver resembles the nutmeg. So we call the nutmeg liver. Nutmeg liver. So as we said that during the chronic venous hyperemia, the tissues became the hypoxic, and the sclerosis develops here, and the permeability of the blood vessels increasing, that they result the diapedesic hemorrhage. When the erythrocytes leave the bloodstream, they undergo the hemolysis, and from the hemoglobin here develops the hemosiderin. That the accumulation of the hemosiderin, there results the hemosiderosis, and after this one here develops the scar tissue. So, for example, in the lungs, we discussed about the liver. Now you see the slides, the gross pathology, gross view of the lungs during the venous congestions. We call it the brown induration of lungs, because in the lung parenchyma we see with you the siderophage, the macrophage that engulf the hemosiderin. So we call the brown induration, or the brown induration of the kidneys. Also here the results is the diapedesic hemorrhage, but in the spleen we call it the cyanotic induration, because here not appears the diapedesic hemorrhage, but the color became to the cyanotic, the bluish. It was the hyperemia. Now let's discuss the ischemia, the against pathologic process to the hyperemia. Hyperemia, it means that increasing the volume of the blood, but the ischemia, this is the decreasing the blood, tissue blood, or we call the local anemia. There are two types of the local ischemia and generalized ischemia. The local ischemia occurs in blocking type, but for example, the blocking of the blood supply of the some regions. But generalized ischemia can be developed after the massive bleeding. So the features of the ischemia: the skin blanching or the disappearance of previously visible small blood vessels, decreased organ or the tissue volume, the lower local temperature, slowing of the blood flow, your fall of the blood pressure below the obstruction, the sensory disturbances, pain, the malfunction, degeneration, necrosis, and finally the sclerosis. There are four types of the local anemia. angiospastic. What meaning? The spasm of the arteries. Obstructive. For example, obstruction by the thrombus. About the thrombus we'll now discuss. Compression, the external compression by a tumor or scar, and anemia as a result of blood redistribution. Outcomes of the ischemia, maybe acute and chronic. If the acute outcomes, it may be a reversible process to the normal state. For example, if there is the thrombus in the artery, in some artery, if we'll treat it by the stenting or by the balloon dilatation, it will be reversed. Or the maybe results the infection. We started with you during the necrosis type of the necrosis, the infection, acute organ failure, or the chronic outcomes. As we said, the fibrosis, sclerosis, and the chronic organ failure. This is the outcomes of the ischemia. One of the big group of the pathology is the hemorrhage, bleeding, that results by the it depended on the integrity of the blood vascular wall. So the hemorrhage is the extravasation of erythrocytes. So the leaving of the erythrocytes from the blood vessels or the heart cavities into the extravascular space or the body cavity. For the entering of the blood, there are two types of the hemorrhage. We call it external hemorrhage and internal hemorrhage. External hemorrhage, it meaning that bleeding to the external environment, such as from the gastrointestinal tract. For example, if the patient has the ulcer, the chronic ulcer, gastric ulcer, the bleeding from the ulcer, to which group we can add the bleeding from the gastric ulcer? Who can answer me?
External?
External, yeah. Or the internal hemorrhage. For example, the patient has the rupture of the ovarian cyst, lady, and the peritoneal cavity filled with the blood. So we call it the internal hemorrhage. So if they starts from the arterial blood vessels, we call the not arterial blood vessels, arterial blood. We call it the arterial hemorrhage. If it is the venous blood, venous hemorrhage. By the starting of the which vessels, if it starts from the heart, we call the cardiac, from the aorta, aortal, from the arteries, another arteries, arterial, venous, and capillary hemorrhage. There is some morphological types of the hemorrhage. Hematoma, probably you heard about the hematoma, but the suffix oma, it did not mean the blood tumor. This is not tumor. This is the hemorrhage with formation of a cavity filled with blood. Another types of the hemorrhagic infiltration, the impregation of tissue with blood-preserving tissue components, or bruise, the planar hemorrhage in the skin, the mucosas, or the dot-like, the punctate hemorrhage in the skin, for example, the petechia or the ecchymosis, apoplexy, the rapidly developed massive hemorrhage. And here you see the hematoma. Also the cerebral hematoma. We'll study in the next term during the cerebrovascular diseases. Here you see the radiology and the gross view and the histopathology of the hematoma. Oh, the indicating of the hemorrhage. There are different terms for using the hemorrhage from some organs. At home, probably you will study this one. For example, epistaxis, the bleeding from the nose, the nasal hemorrhage, or the melena, the fecal blood, the blood in the fecus, or the metrorrhagia, the uterine bleeding, the uterine cavity hemorrhage, hemoptyoi, the respiratory tract hemorrhage, or the cathecal blood, hemopericardium, the blood in the pericardial cavity, hemoperitoneum, accumulation of blood, and so on. Hematuria, blood in urine. There are three mechanisms of the hemorrhage. First, the hemorrhagia per rexen. It means the rupture of the vascular wall by the injury, by the inflammation, necrosis, aneurysm, vascular malformation, sclerosis, hyalinosis. So in these conditions, the blood ruptures. For example, the mechanical, by the charm, by the knife, for example. Second one, we call it the hemorrhagia per diabrosum, for the abrasion, vessels, wall, or the vascular wall corrosion. It may be by the tumor, necrosis, inflammation, ectopic pregnancy. One example, as we said, from the during the gastric ulcer, there is some bleeding. It results by the hemorrhagia per diabrosum, or the tumors. They erode the wall of the blood vessels. And finally, the interesting types of the hemorrhage, the hemorrhagia per diapedesis, or the through the intact wall. During this type of the hemorrhage, the integrity of the blood vessels is not destroyed. The erythrocytes leave the vascular or the arterial wall by the diapedesis. It may be during the hypoxia, intoxication, hemorrhagic diathesis. What means the hemorrhagic diathesis? Is the hemorrhage tendency stages during the angiopathies, thrombocytopathies, and the coagulopathies. The outcomes of the hemorrhage: the resorption with formation of the blood pigments, such as the hemosiderin, or the cyst formation after resorption of blood. The next term will study with you the hemorrhagic infection of the brain, hemorrhagic stroke type of them, or the organization, the encapsulation and germination, the connective tissue of hematoma, the formation of the scar tissue, and the accession, infection, and suppuration. This is the outcomes of the hemorrhage. Also, one block of our today's topic is the thrombosis. What means the thrombus? I think you know from the physiology. Thrombus, this is the blood clot. Yeah? It represents hemostasis in the intact vascular system, that the formation of the thrombus, this is the solid mass, blood clot, may be developed in the artery and veins. So the etiology, cause of the thrombosis, there are three major factors. We call it the Virchow's triad. First, the endothelial damage, the slowing and the turbulence of the blood flow, and the change in the blood composition. I will not focus by this pathogenesis. During the lecture, we discussed about this one. And here you see the Virchow's triad, the endothelial damage, the abnormal blood flow, and the hypercoagulability, the increasing the coagulation ability of the blood. The stages of the thrombogenesis, the vascular platelet stage, as we said, the damage of the endothelium, adhesion and aggregation of the platelet, and the formation of the platelet thrombus. Here, this is the electron microgram of the platelets, thrombus. Then second one, coagulation stage, the thrombokinase formation, the thrombin formation, and the fibrin formation, and the blood clot retraction. And here you see the histologic view of the thrombus. On the endothelial defect. This is the wall of the arteries during the polyarteritis nodosa, the rheumatic diseases that we will discuss about the next semester. You see here the big thrombus in the wall of the arteries. So after 10 minutes, I will update our classes. So when while there is thrombus that they develops in the living body, in the wall of the blood vessels, Or another one, during the autopsy, we found some blood clot in the blood vessels. How we can we have differentiate from the thrombus or the post-mortem blood clot, the blood clotting after the death. So there are some morphological features. The post-mortem blood clot is the G-like and flexible, that they located freely. They're not attached to the wall of the blood vessels. Mainly it found into the venous blood vessels with a smooth and shiny surface. But the thrombus, it mainly found in the arterial bloods, that they firmly attach with the vascular wall and with the corrugated surface that depended on the pulsation. And in the microscopically, a very interesting finding, we call it the lines of the Zahan. You see here? This is the lines of the Zahan inside of the thrombus. So grossly, this is the thrombus of the aorta during the atherosclerosis. Aorta, as we said, the arterial blood vessels, arteries. But here we see the post-mortem blood clot in the pulmonary artery. So we have to differentiate, as well as in the forensic pathology, in the autopsies, in the pathology autopsies, the real thrombus from the blood clot. So there are 4 types of the thrombus. Here, Mr. One of the time, the white thrombus, that here prevailed the leukocytes, red thrombus, mixed thrombus, and the hyaline thrombus. There are 4 types of the thrombus: white, red, mixed, and hyaline. Hyaline thrombus, here the proteins they destroyed, and they forms the hyaline thrombus. So there are, in relations to the vessel lumen, there are mural thrombus and occlusive thrombus. The occlusive thrombus, they wholly fill the blood lumen, the blood vessels lumen. There are still special forms of the thrombus: the progressive thrombus, ball-like in the left atrium, dilatation thrombus, microthrombus, and then finally there is the fibrinolysis, the thrombus dissolution. In our blood, there are 2 functional systems: the coagulation and anticoagulation, or the fibrinolysis system. So here I will show you the occlusive arterial thrombus, that they completely blow the lumen of the arteries. Here we do the gross picture of the thrombus. We indicate the head, body, and the tail of the thrombus. And sometimes some part from the head region, they ruptures and they result by the thromboembolism that we'll now discuss. Here you see the ball-like thrombus in the left atrium. Microscope of the thrombus. This is the coronary artery of the heart. And the inside of the coronary artery, we do the thrombus, that formation of the fibrin nephron. This is the late stage of the thrombus that they undergo to the organization. And outcomes of the thrombosis. We can divide the favorable and unfavorable. The favorable may be aseptic autolysis, organization and vascularization, and putrefaction, the sedimentation of the calcium salt. And unfavorable, the septic autolysis, the thrombobacterial embolism, sepsis, and thromboembolism. This is the unfavorable, worst outcomes of the thrombosis. And here we see also again the organized thrombus in the coronary artery. Normally, the lumen of the artery must be these lines, but we do that the lumen of the artery filled with the thrombus that undergo the organization. So the embolism. What means the embolus? This is the foreign particles that circulated in the blood and lymph that followed by blockage of blood vessels. There are orthograde embolism with the blood flow, retrograde against the blood flow, and paradoxal, the moving of the embolus from the arteries to the veins, bypassing the microcirculation. So there are some types of the embolus according to the aggregate stage. There are the solid emboli, such as the thromboembolism, tissue embolism, microembolism, and foreign body embolism. Liquid embolus, the fatty embolus, gaseous embolus, the air and the gas embolus, and the mixed, for example, the amniotic fluid embolus. The thromboembolism, the 80% of the thromboembolism, they result by the thromboembolism. There are arterial and venous types of the thromboembolism. The arterial thromboembolism, the source from the left cavity of heart, the aorta, and other arteries, the thrombus comes. That they result by the infection of the various organs and tissues, such as the gangrene and ischemic cerebral stroke. But the venous thromboembolism, the thrombus comes from the systemic circulation. For example, the thromboembolism of the pulmonary artery, very worst diagnosis. So thromboembolism, as we said, that there are two kinds, the arterial and venous thromboembolism. And the thromboembolism of the pulmonary artery, very worst pathologic process that they mainly result fatally. And here you see the thrombosis in the main branch of the pulmonary artery that they result with the sudden death because it affect to the reflogenic area in the bifurcation of the pulmonary artery. So the as we said, there are some types of the embols and tissue cell embols. These are the malignant tumor cells that enter to the blood vessels or the lymph vessels, lymphatics, and the blood vessels, and they circulated with the lymph or the blood. Then they destinate to another organs and start to develop again. So we call it the metastasis. The metastasis of the malignant tumor, there are the tissue cell embolism. Here we see we do the histology, histopathology of the breast cancer, and the breast cancer into the lung. This is the biopsy taken from the lung. And inside of the pulmonary parenchyma, we see we do the islets of the breast cancer metastasis. Or the microbial embolism, some bacteria, fungi, some parasites, the protozoa, they can flow by the blood and result the microbial embolism during the sepsis, for example, or the embolism by foreign bodies, the fragment of the shells and the mines, the bullae, or the cholesterol crystals of the atherosclerotic plaques. Here we see we do the microbial embolism. This is the suppurative or the purulent nephritis. In the kidney, the biopsy from the kidney, we see the accumulation of the microbes, microorganisms. Here in the high power we see video. Or the fatty embolism, the entering of the fats, the molecules to the blood vessels, and the results of the embolism. For example, it results during the fractures of the long bones or during the massive subcutaneous tissue. They affects the acute pulmonary failure or the cardiac arrest if they will blockade the 2/3 of the pulmonary capillaries. This is the biopsy taken from the lungs, and here we see the 1, 2, 3, 4 fatty droplets inside of the lungs, the arteries. Here also we see we do the fatty embolism inside of the bone marrow fragments, and you remember the staining of the oils that we when we use the oil red staining, we can find the fat emboli. Or air embolism, air embolism. During the injuries of the neck veins, cervical veins, during the injury of the uterus veins after the childbirth, the air can enter to the blood vessels that results with the sudden death. Or the gas embolism, they resist before because the divers they enter during the diving, they cause the mainly the azote, they enters to the blood vessels, they by resulting the embolism. Or very some interesting type of embolism, amniotic fluid embolism. During the delivery, during the birth, the cervix, uterine cervix of the mother ruptures, and some elements of the fetus. It may be the liquid part, the tissue thromboplastin, the solid fetus elements, the meconium, the fecus of the fetus, or the scales of the epidermis, fat, lanugo, the primary hairs of the fetus can enter to the mother blood vessels. So they result by the DIC syndrome. What means DIC syndrome? This is disseminated intravascular coagulative syndrome. This is a very interesting histological slide that shows that amniotic fluid embolism. This is the scales of the epidermis from the fetus inside of the mother's blood vessels. So DIC syndrome, the disseminated intravascular coagulation, very seriously or worst syndrome. Another name is the thrombohemorrhagic syndrome or the conception coagulopathy. This is the acquired non-specific process of the hemostatic disorders develops as a result of excessive activation of the coagulation and anticoagulation systems. The main symptoms are the phase change of hemostasis in a hypercoagulative state that is replaced by the incoagulability, the blockage of microcirculatory by aggregation of blood cells and microthrombus, and bleeding and hemorrhage, so apoplexy. Etiology, they may can develop during the infections, especially by the sepsis, during all types of the shock, during the acute intravascular hemolysis, during the obstetrical pathology, during the tumors, the burns, then extreme trauma. So the pathogenesis. First, the hemostatic system activated by the various factors. For example, as we said that the tissue thromboplastin enters from the fetus to the mother body. So it results in diffuse intravascular coagulation and aggregation of blood cells, mainly in the microcirculatory system. Then conception of the coagulopathy, then spread of the hemorrhage, and active change in various organs and tissues. There are 4 stages of the DIC. The stage 1, the hypercoagulation and aggregation of the blood. Stage 2, the transitional, that in the laboratory, the normal blood clotting time, but the decreasing the fibrogen content and thrombocytopenia. Stage 3, the hypocoagulation, and stage 4, the regenerative or outcomes of complication. So there are 4 stages according to the quarter: pre-acute, acute, subacute, and chronic. The direct signs, the aggregation of the blood elements and the fibrin structures, that individual fibers and the bundles of fibrin in subthrombus, covering of fibrin layers with the vessel walls, and the microthrombi, the fibrin, hyaline, globular. Mainly we found the hyaline thrombi. And indirect signs, the hemorrhage and necrosis. Here we see the pathology of the disseminated intravascular coagulation, the hyaline thrombus in the lungs. This is a PAS staining. And here also we can find in the kidney, the hyaline thrombus during the disseminated intravascular coagulation. And the fourth stage, this is the shock line in some internal organs. Here results a very serious process. For example, the diffuse alveolar damage in the lungs, the acute respiratory distress syndrome, the edema, hemorrhage, aggregation of the red blood cells, microthrombosis, hyaline membranes. For example, the results the shock. During the bacterial shock in the kidneys, the symmetrical cortical necrosis, during the meningococcemia, the hemorrhage and necrosis of the adrenal glands, the multiple small focal necrosis and hemorrhage of brain, hypophysis, myocardium, liver, pancreas, hemorrhage and erosions and the ulcers of gastrointestinal tract. Here you see the gross pathology of the lungs during the diffuse alveolar damage and the histopathology of the diffuse alveolar damage. And finally, let's discuss about the lymph circulatory disturbances. The increased fluid in the interstitial tissue space we call the edema. So the fluid may also accumulate in the three body cavities. In the thoracic cavity, we call it the hydrothorax. In the pericardium, hydropericardium. In the peritoneal cavity or abdominal cavity, we call this ascites. The massive generalized edema, we call it as anasarca. So the homeostasis is maintained by the vascular hydrostatic pressure and the plasma colloid osmotic pressure. Here we see we do the increasing number of the hydrostatic pressure that results of the formation of the edematic fluid. So in the next class we'll discuss about the inflammation, and here we also will compare of the transsudate with the exudate. Transsudate is the fluid of the edema, is the protein pure fluid, but the exudate, this is the inflammatory edema. There are four categories of the edema, pathophysiological categories: the increasing hydrostatic pressure, reduced plasma oncotic pressure, inflammation, and others. So the lymphatic obstruction also may result by the edema. So we call this the lymphedema. This is the locally, or maybe due to inflammation or the neoplastic obstruction. Probably you heard about the filariasis. Filariasis, the elephant extremities. This is the filariasis. This is the parasitic infection caused by the infection of the roundworms of the Filaroidea type and affecting the inguinal lymphatics, the results in the elephantiasis. Morphology of the edema: the grossly, not microscopically, the most easily to detect the edema under the skin, the subcutaneous tissue. So here you see the edema. If we'll push our fingers to the to it, the depression will remain in the edema. It may be resulted by the congestive heart failure or the facial edema during the nephrotic syndrome. Pulmonary edema, the most frequently in the congestive heart failure. Here we see with the gross view of the pulmonary edema. So the lungs are typically 2-3 times the normal weight, and the gross sections we see here the outpouring of the frothy, sometimes the blood-tinted fluid, and the morphology, the histology. Here we see the dilatation capillars in the alveolar walls, the thickened alveolar walls with the dilated capillaries, and the transudate that fill to the alveolar lumen. Or the cerebral edema during the trauma, abscess, during the tumors, infections maybe. And there is a big problem that during the cerebral edema, the fluid can't find the places for the flow. For example, when the fluid accumulated in the abdominal cavity, it results not so serious problems, yet sharply, acutely. But the fluid, when the fluid they accumulated in the brain, you know that there is no any places for outflow, and the fluid they flow through the foramen magnum of the occipital bone. When they flow through the foramen magnum, it presses the medulla oblongata to the bone. So we know from anatomy that there are many vital centers located in the medulla oblongata. One of them, the respiratory center. So during the destroying of the respiratory center on the medulla oblongata, it results by the death of the patients. So we finished our